Good afternoon, one and all. I'll be presenting pressure downfall with a twist, a case on ocular decompression retinopathy after scleral fixated intraocular lens. Let's start with the background introduction first. So, ocular decompression retinopathy was first coined by Fechner et al. In 1992, wherein you can see multiple layered retinal hemorrhages due to an abrupt and iatrogenic fall in intraocular pressures in an eye previously having an high intraocular pressures. Basically, it usually occurs after glaucoma filtering surgeries, but there are a few case reports wherein these condition can also occur in after posterior segment procedures as well. So keeping that background in mind, we'll just look at the case report. So this is a 17-year-old male which had come to us with acute onset painless diminution of vision in the left eye since 10 days with post-trauma with a stone. He was started on anti-glaucoma medications from elsewhere in the left eye because of raised IOP. Patient did not have any systemic medical illnesses as such. The right eye anterior segment and the fundus was within normal limits, whereas the left eye showed a few endothelial pigments, 1.5 millimeter hyphema, and cells in the AC, and multiple sphincter tears and a traumatic mydriasis. The left eye best corrected visual acuity was PLPR accurate with an intraocular pressure of 40 millimeters of mercury. He also had a left eye totally anteriorly subluxated traumatic white cataract with vitreous prolapse in the anterior chamber. The fundus was not visible at all, but the B scan showed that the retina was attached. So he was diagnosed as left eye traumatic subluxated cataract with a secondary glaucoma. He was started on topical steroids and cycloplegics for the same. And he was observed on maximum medical therapy for 2 weeks. But in spite of that, he was having a raised intraocular pressure of 31 millimeters of mercury. So the patient underwent left eye intracapsular cataract extraction with anterior vitrectomy. In spite of that, again, he also had persistent raised IOP for 1 week. That was 40 millimeters of mercury. But the left eye visual acuity best corrected was with plus 10 DS was 20/80. He was having surgical aphakia with some amount of cortical matter floating in the vitreous due to pre-existing PCR, along with disc damage as well. He was kept on medical management for 2 weeks or so, but again he was undertaken for pars plana lensectomy along with secondary intraocular lens implantation after the primary surgery. Here is a post-operative picture of 5 days of the left eye. You can see the stable SFIL in the patient and a resolving corneal edema. The visual acuity was 20/200 with an intraocular pressure of 14 millimeters of mercury of any AGMs. But as you can see in the fundus photograph of this left eye, you can see the disc cupping and the normal retinal vasculature. Also on zooming in, you can see multiple subinternal limiting membrane hemorrhages which are scattered throughout the posterior pole and mid-periphery. And also there are a few white-centered hemorrhages which you can confirm on the red-free imaging as well. So this was diagnosed to have an ocular decompression retinopathy in the left eye. The hemorrhages which you can see have resolved over 1 week or so, and the visual acuity remains stable at 20/60. If we look at the pathogenesis of ocular decompression syndrome, there are two theories in literature which you can see, which is a mechanical theory and the vascular theory, wherein the mechanical theory states that there is a scleral prolapse and mechanical capillary shearing which leads to the hemorrhage. Another theory also states that there is an anterior movement of the lamina cribrosa, and because of that the exoplasmic flow is impeded. And lastly, there is an anterior egress of the fluid from the posterior segment into the anterior chamber post YAG iridotomy, causing a posterior vitreous detachment and a vitreous hemorrhage. The vascular theory also states that there is a fall or a loss of autoregulation of intraocular pressure, and also there is fragility of the capillary vessels which leads to the vitreous hemorrhage and the multiple layered retinal hemorrhages. There are a few differential diagnoses of mimickers which we need to keep in mind, which is central retinal vein occlusion, valsalva retinopathy in particular, wherein a CRVO also shows venous dilatation and multiple tortuosity of the vessels, and the patient is usually symptomatic and the visual gain is poor. On the other hand, valsalva retinopathy can occur in an eye without an ocular iatrogenic intervention, and pre-retinal hemorrhage are usually distributed along the macular region. Ocular decompression retinopathy usually resolves in as short as 2 weeks, and it can take as long as 72 weeks as well to resolve. In most patients, usually no treatment is required, but there are a few patients wherein vitrectomy is required to remove a visually significant or a non-resolving vitreous hemorrhage. Here, the importance of adequate preoperative reduction of IOP is reiterated, and it is of utmost importance. To conclude, ODR, as you can see, is a rare condition occurring due to sudden iatrogenic decrease in IOP, and it is characterized by multiple layered retinal hemorrhages. Usually has a benign cause, good baseline vision is usually retained, and it is post-spontaneous resolution of these hemorrhages. Lastly, adequate precautions to prevent this entity should be adopted during surgery, especially by maintaining a perioperative or preoperative hypotony.